Welcome, clinical problem solver. It's great to see everybody this morning. I will wait for the anxious anticipation of seeing cameras come on, but I just want to say thank you all so much for joining us today for another virtual morning report. For those of you who I haven't had a chance to meet, my name is Jack. I'm an internal medicine chief resident out here in San Francisco, but more importantly, I'm thrilled to get to facilitate morning report today. Whether it's your first time, your fifth time, or your 500th time at morning report, we are super excited to have you here today. We have a bit of a small crowd today, and so first things first, we'll just put out a call to see if anybody is interested in presenting a case today. And then for our normal format for morning report, we ask two volunteers to step into the lukewarm seat. But if there's nobody who's feeling necessarily particularly excited about stepping into the lukewarm seat to discuss a case today, we can also do it in a little bit of a different format, which is where we can sort of all just discuss the case together. Feel free to type your thoughts in the chat. I may ask you to unmute here and there, but we can sort of almost do like a small group problem solving session rather than having two discussants. So again, feel free to volunteer if you're feeling compelled to discuss, but there's no pressure to, because we can always pivot to a bit of a different style. But I would love to ask, does anybody have a case that they would like to potentially present today? We'll sit with the silence for a little bit and see where the cases come from. All right. Not looking like much of a case yet. All right, and then is anybody feeling excited about discussing or stepping into the lukewarm seat to think through a case together? Awesome. Well, it looks like Rafa has a case, and we're not getting too many volunteers here in the chat. So why don't we have Rafa present the case, and then what we can do is Rafa will present the aliquots to us, and then for those of you who have thoughts that you want to share, please do type them in the chat as the case unfolds, and then we'll hopefully be able to sort of talk through the case together. But we can just dive right into the case today and see if we can get some juices flowing. And then also, if you could do me a favor, if you're comfortable, share where you're joining VMR from today. Just I think it's always exciting and honestly quite moving to see how many people join this session from across the world. So really want to highlight the international audience here. So yeah, please do, if you have a keyboard nearby and feel comfortable doing so, let us know where you're joining VMR from today. But otherwise, I will turn it over to Rafa to introduce himself and go ahead and take us away with the first aliquot.
Okay, so hi everyone. Hope everyone is having a good time today. And my name is Rafael, and I'm a last year medical student here from Brazil. I'm also a clinical problem solver member, and we highly encourage everyone here to present cases and participate with us in the discussion. It's so much fun, and we can learn so much from each other. So the case that I'm presenting is about a 48-year-old female with facial hair and acne, and that's the end of the aliquot.
All right. So as people start to think through this information here, right? Just to sort of characterize the chief concern that we have here is sort of a disease process that we could that somebody may describe as hirsutism, or the development of features suggestive of elevated androgen levels in the bloodstream, and particularly elevated levels of the sex hormones that will facilitate facial features that we traditionally see in those of the male sex. So I'm going to leave a couple seconds for people to just sort of put some ideas in the chat, but we can also talk through kind of what exactly this means overall. Just going to set up my screen here. Does anybody have thoughts or ideas here so far? Feel free to unmute and share them or type them in the chat. So I see Kirtan mentioning endocrinologic versus malignancy. Kirtan, go ahead and unmute and share a little bit more about what you're thinking there.
Yes, sure. So I think Dr. Thiago Mendes, who is our beloved, team member and regular participant on VMR, so he has numerous times shared his thinking regarding facial hair and acne. So first and foremost, we have to think about the common things. So the base rate of disease is very important. So the patient is female and the patient has facial hair and acne. So things like polycystic ovarian syndrome is something we should come into our mind. Now, usually PCOS is something which occurs in younger women, so something like 20 to 30 years of age, but still we can't rule it out just yet. So we have to think about polycystic ovarian syndrome. Apart from that, because of the age of the patient and the patient is, around perimenopausal period, one of the other things which I'm worried about is presence of some malignancy. And the reason why I'm telling about malignancy is that because many ovarian tumors and adrenal tumors can sometimes secrete variety of hormones which can disrupt the delicate balance of estrogen and testosterone, because we know that testosterone is acted upon by aromatase to form estrogen. So many imbalances can occur at the level of this enzyme, and that can elevate the level of free testosterone. So even if total testosterone are normal, I wouldn't dissuade from considering that possibility, because the free testosterone levels may be elevated, and that might be contributing to facial hair and acne. And sometimes this may be the only sign of a malignancy. Patient may not complain of weight loss, patient may not complain of abdominal discomfort, and we know that ovarian malignancies are notorious. So we find them and they are like grade 4 or grade 3. So we have to understand that this may be a malignancy. So we have to rule out those must not miss causes. And then maybe we could look at things like hypothyroidism, or other adrenal defects which can present in this manner. So those are my thoughts. Now, Jack, can you help us how to zoom in further along these possibilities?
Yeah, so I mean, I think Kirtan, that is an absolutely fantastic overview here, and I think at this point in the case, it's really hard to make a lot of progress without some more information about sort of what some of the other associated features may be. I think it has come up in the chat that the tempo of how this develops is actually quite important and can be quite helpful here, as is more background information about where this patient is in terms of her general menstrual cycle over the course of her life, and specifically help trying to understand, is she perimenopausal, premenopausal, or postmenopausal, because the evaluation is going to be a little bit different. I think the most important thing to take away at this point is that these features, the combination of facial hair and acne, are suggesting increased levels of the androgenic hormones, particularly testosterone, and DHEA. And exactly as you said, Kirtan, there's a number of different ways that we can get down that path, one of them being malignant causes, the other being non-malignant causes, that we can sort of further stratify based off of the base rate of disease, but also based off of sort of where, what structures this is actually coming from. So for example, if we were to take all comers, the most common cause of hirsutism and sort of elevated androgenic sex hormones would be polycystic ovarian syndrome, right? And so we can start to look for features of PCOS based in the history. Is there a history of irregular menses? Is there a history of particularly heavy menses, long periods of time without regular, or I should say normal menstrual cycles in terms of their frequency, and potentially other symptoms that we may see coexisting with PCOS, things like insulin resistance, or other features of metabolic syndrome. Then we can think about, so there's sort of the PCOS category. There is also the category of sort of non-malignant changes within the reproductive tract. For example, many of the stromal cells within the uterus can undergo what's called luteinization, and so rather than producing some of the non-androgenic sex hormones like estrogen and progesterone, they luteinize and start to respond to luteinizing hormone and produce the androgenic hormone. So those would be sort of two non-malignant causes of ways in which we can sort of mediate these hormones. But really, where the most, I think, diagnostic utility up front is going to come from is understanding the tempo that this developed over, an acute development of these symptoms that are rapidly progressive is going to increase the probability of this being a malignant cause that is having very, very high hormone production. And then also getting more information about where she is in terms of what her normal menstrual cycle looks like, but also what her menstrual cycles have looked like over the course of her life. So we can sort of understand whether we're dealing with a pre, peri, or post-menopausal patient, because each of those will help shift the differential a little bit in terms of the probabilities of the different diseases. So I'll turn it back over to you, Rafa, to take us through this a little bit further.
Okay, so now I'll go all the way before the physical exam, if that's okay for you. Okay, so this is a 48-year-old female that presented with a 2-month history of virilization. She first noticed the appearance of acne on her face and the upper back. This was followed by the development of hair on her chin and at both angles of her jaw. Over the past month, others have mentioned that her voice has become deeper. And her revealed system also reveals progressive shortness of breath over the past 2 weeks. Further history. She initially presented to her primary care physician, and an evaluation revealed the new elevation of her blood pressure. This was 175/90. The primary care physician also noticed a significant hypokalemia of 2.3. And based on this new elevation of her blood pressure and significant hypokalemia, the primary care physician advised the patient to present to the emergency department. And that's the end of the aliquot.
Excellent. So it seems like we have some actually very, very, very interesting background history here. And just to sort of highlight, right, we have this initial disease syndrome that was characterized primarily by features suggestive of elevated androgenic hormones, right? That being things like the facial hair development or hirsutism, as well as the acne. And then we're seeing, not only in this aliquot, more and more signs of elevated androgenic hormones, but also some other abnormalities that don't necessarily map on perfectly to our illness script for elevated androgens in and of themselves. And those features particularly are things like the presence of hypertension, as well as the presence of hypokalemia, right? So androgen sex hormones in and of themselves don't necessarily mediate our serum potassium levels, things like testosterone, DHEA. The things that mediate our serum potassium levels are primarily going to be things like aldosterone, for example. And so if we're now asking ourselves, are there other coexisting endocrine abnormalities that could be mediating some of these findings? We have to ask ourselves, what are the elements of the hormonal axis, which is where our center of gravity is focusing right now, given the presenting features? What are the elements of the hormonal axis that can mediate things like blood pressure as well as potassium levels? So the question then, I will turn that over to the group. If you all would be up for it, type some hormones in the chat that you think of as mediating blood pressure as well as potassium levels. Aldosterone, great. Kushal, unmute. Tell me a little bit more there about what you're thinking.
Yeah, so whenever there is hyperaldosteronism, you would see hypokalemia and metabolic alkalosis and hypertension. So that's the one that I can think of.
Great. So we have features here now of elevated aldosterone levels, which would be sort of compatible with this finding of elevated BP and hypokalemia. The other thing that can potentially come alongside or closely alongside aldosterone is going to be some of the other adrenal hormones we see, right? So when we think about aldosterone, it's also important for us to think together about cortisol. If aldosterone is mediating blood pressure and potassium, cortisol will also have some impacts on blood pressure, as well as potentially having impacts on sodium levels as well as insulin resistance. So one thing that would be interesting to understand is, are we also seeing features developing of insulin resistance in this patient over time? Kurtan is mentioning in the chat that Cushing syndrome starts to become high. We may oftentimes think about Cushing syndrome as being associated with cortisol rather than with aldosterone levels, but it's important to note that if the adrenal glands are being stimulated overall, they won't necessarily be super selective in terms of the hormones that they produce. So if we have overstimulation of the adrenal glands, we will make increased levels of all of the adrenal hormones that exist, right? If we think about the adrenal glands making the three classes of salt, sugar, and fat hormones, the salt hormones being things like aldosterone, the sugar hormones being things like cortisol, and sorry, salt, sugar, and sex, not salt, sugar, and fat. That's a cooking book that you should check out because it's quite good. Salt, sugar, and sex, and then the sex hormones being things like the androgenic hormones. So the fact that we have things like virilization and hirsutism plus hypertension and hypokalemia start to paint a picture of us here of general adrenal hormone excess. We're missing features of there being hypercortisolism so far, but we can be on the hunt for what some of those findings are, and we'll see if those end up coming up. The question then becomes, how do we confirm the presence of excess of adrenal hormone excess? And that will come from not only exam findings, but also laboratory features. But then we have to go on the hunt in terms of figuring out what exactly is stimulating it. Is there something within the pituitary axis that's leading to excess levels of ACTH? Or is there potentially something outside of the pituitary axis that's producing ACTH on its own that's then causing stimulation of the tumors? The reason that I mention excess or something outside of the pituitary axis is because we have this interesting feature of shortness of breath, which if we think about how do we link shortness of breath to this finding here, there's a couple ways to do it. One is, right, we can think about cardiac manifestations of shortness of breath, something like somebody developing heart failure or a cardiomyopathy. If we have significant amounts of volume retention, that can mediate us falling off of our Frank-Starling curve, accumulating water retention, developing some subtle pulmonary edema, and a clinical syndrome of heart failure, right? Most individuals who have a normally functioning heart up front probably won't develop symptoms of heart failure just from volume retention because their kidneys and their heart will accommodate the volume load and help us urinate it off. However, if there's a pulmonary process that could be causing shortness of breath, there also are pulmonary processes that can mediate adrenal stimulation, and that's going to be particularly rare, but important to note, a neuroendocrine tumor like a small cell carcinoma that can produce ectopic ACTH hormone that can then stimulate the adrenal glands, right? So if we think about how do we map on the shortness of breath to this finding here, the two things that I'm thinking about is this related to cardiac disease that is now being brought out potentially by the hypertension and any sort of volume retention that may be present from what seems like potentially hyperaldosteronism? Or is there a pulmonary process that has developed and that pulmonary process has impact in other parts of the body like the hypothalamic pituitary adrenal axis, and particularly the adrenal glands, because the pulmonary process itself is mitigating hormone production, right? These are all hypotheses at this point before we have the physical exam, but it's sort of some potential ways that we can start to connect the dots between these features here. I see Vale mentioning a really excellent point in the chat here. Vale, do you mind unmuting yourself and sharing a little bit more?
Yes, hello everyone. Well, just again what Kiara mentioned on Sunday VMR, which was that cause of shortness of breath that doesn't necessarily affect the lungs or the heart directly, but like obesity. And if this patient has, for example, truncal obesity, they can explain a decrease in the functional vital capacity, and because of that, an increase on the respiratory rate and shortness of breath.
Yes, excellent. It's such an important point, right? Before we go into the world of esoteric rare diagnoses like the ones that I'm mentioning, it's important to sort of root ourselves back into the base rate, which you did brilliantly here, Vale, right? Not only thinking about, is there a direct cause between the shortness of breath and the virilization, but is there also just coexisting common causes of things that can cause shortness of breath, particularly things like increased adiposity or overall increased body weight. So just to sort of summarize where we're at here, right? We're sort of sitting in the space of the endocrine axis by virtue of the features that we have, right? The features that we have started with particularly the androgenic hormones as where we were starting. And then we had features of some of the other adrenal hormones coming out, like the hypokalemia. So the center of gravity is going to be on the endocrine axis right now. Kind of in our peripheral vision, we have things like the shortness of breath and the lungs. Whether we can draw a straight line between those, or there's a third part that's mediating the shortness of breath, something like obesity, as Vale mentioned, is still up in the air. But where we're going to go from here now is going to be focusing on, can we find exam findings and lab findings that help us further paint a picture of adrenal hormone excess? And if we can, then the hunt is going to be on to figure out where that adrenal stimulation is coming from. So I'm going to kick it back over to Rafa here to give us a little bit more information about the physical exam so we can continue to work our way forward.
Okay, so the heart rate was 80. The blood pressure was 181 per 102. The respiratory rate was 20. She's saturating 97% on room air, and the temperature is 36.7 Celsius. Her HEENG exam confirms the findings of hirsutism mentioned above, but also Cushingoid appearance of her faces. Cardiac exam is normal. Respiratory shows diminished breath sounds over the left lower lung field, and otherwise normal. So diminished breath sounds over the left lower lung. Abdominal exam shows a soft, non-tender, non-palpable mass. And the remainder of the examination was unremarkable. I'm going to give you just a little bit of initial labs. So the hemoglobin was 11.7. The white blood count was 6.8. And the platelets were 394. The sodium was 133. Potassium 2.2, chloride 99, bicarb 23, creatinine 0.8, random glucose 153. Oh, the creatinine was 0.8. And the calcium, the magnesium, and the phosphate were all normal. And the AST, ALT, ALP were all normal. Bilirubin was normal as well, and the albumin was 3.4. The INR and PPT were both normal, and the EKG showed a sinus rhythm with U waves, and that's the end of the aliquot.
All right. So indeed, a fuller and fuller picture here continuing to be painted by another fantastic case from Rafa. Thank you for bringing this one to us today. I'm going to leave a few seconds just for people to kind of gather their thoughts, and I'll ask just to share one, maybe two things that are jumping out to you on physical exam as being particularly helpful in moving us forward through this case. Ooh, Gabriel, this is an excellent hypothesis. Tell me, what are some of the features that are helping you generate this hypothesis here? And then tell me kind of what this specific diagnosis is that you're thinking of, right? How are you connecting the exam and the labs here to this question of ovarian cancer with a pleural effusion?
Yeah, so as we were talking before about some types of ovarian cancer can produce certain hormones that can stimulate hormones related to the blood pressure and the potassium regulation, and also the cortisol. So that with the presence of diminished air over a lung base and also the abdominal mass, I can think of maybe an ovarian cancer presented with pleural effusion because it's one of the complications. And I'm not sure if I'm saying the name of this condition right, but I think it's called Meg Syndrome. Maybe you guys can correct me about it. But yeah, I was thinking about it.
I think that is absolutely brilliant reasoning here, right? Sort of how are we connecting these new pieces of information that got added to this case, which include the palpable abdominal mass, now focal pulmonary findings, right? We just had the hypothesis of the lungs before, but now that probability goes up with these focal pulmonary findings, combined with the total picture of, again, increasing evidence of adrenal hormone excess, right? The Cushingoid appearance is suggesting hypercortisolism. The hypokalemia is potentially suggesting hyperaldosteronism, and then the virilization is reflecting hyperandrogenism. So all three layers of the adrenal gland here. There's also the potential for epinephrine and norepinephrine being stimulated by adrenal excess that could further mediate the hypertension that we saw earlier on in the case. But it seems like we have adrenal excess. And then Gabrielle took us perfectly through thinking about, gosh, well, is this something that is within the endocrine axis or something outside of the endocrine axis? I see Nagam also mentioning this entity of Meg syndrome that Gabrielle mentioned here. And I sincerely apologize if I pronounced your name wrong, but would you be willing to unmute and share a little bit more about what you know about that disease entity?
Yes, sure. Hi, everyone. It's actually my first time joining one of these Zoom meetings, so I'm very happy to be here. And thank you for presenting this nice case. It only occurred to me when our previous colleague mentioned ovarian cancer, and it is a syndrome with a triad of an ovarian cancer or mass with a pleural effusion and ascites. Maybe some of the things that are going against that is the fact that there's no palpable mass in the abdomen, and perhaps we still don't have a sign of ascites in this particular patient, but it's something that might explain some of these symptoms.
Nagam, first off, thank you so much for being here. It is so exciting to see somebody who is joining for the first time, and an absolutely brilliant reflection here, right? One way that we can think about connecting intra-abdominal processes to pulmonary processes in a premenopausal woman, particularly if we're thinking about the endocrine axis and potentially reproductive organs here, would be something like Meg syndrome. And you're exactly right. It's the combination of a ovarian mass, ascites, and a pleural effusion. The sort of formal diagnosis of Meg syndrome sort of involves us post-biopsy making the diagnosis, because the tumor is usually an ovarian fibroma, but the clinical syndrome of ovarian mass, ascites, and pleural effusion is sometimes also referred to as Meg syndrome as well. So this we may find that this palpable abdominal mass is related to a ovarian mass, and we can have Meg syndrome as well as sort of variants of Meg syndrome from malignant tumors. So rather than an ovarian fibroma, a malignant ovarian tumor. But I love the fact that I'm seeing everybody here start to connect these dots and thinking about how do we start to reconcile these pieces together. Something else that I will add to the differential, right? Or actually, before doing that, if we sort of are now starting to have increasing evidence of this over adrenal gland stimulation, we now have to ask ourselves: is this something that's being mediated by the known endocrinologic axis, or is there a third party outside of the traditional endocrine axis that's mediating this, right? Because we can certainly have pituitary abnormalities, hypothalamic abnormalities, or primary adrenal abnormalities that all can give us adrenal or excess adrenal stimulation, right? If there is a pituitary tumor that's producing increased levels of ACTH, that can certainly drive us down this route, right? But we have findings now on exam that are taking us outside of the endocrine axis, which is usually not going to, which is usually going to move us away from one of these primary hypothalamic pituitary adrenal axis abnormalities. Those findings, as multiple people have mentioned, are the lungs and this palpable abdominal mass. And so if we have the question of potential cancer plus potential hormone-mediated processes, we can add to that differential diagnosis something like a neuroendocrine tumor. And what neuroendocrine tumors are basically functional visceral organ tumors that produce various hormones, right? Many of you may have heard about the sort of traditional neuroendocrine tumor syndrome, something like carcinoid syndrome, which is from a tumor that secretes neuroendocrine, or sorry, it is a tumor that secretes hormones, particularly serotonin, that then mediates many of the symptoms of carcinoid syndrome. We can also have neuroendocrine tumors that produce something like insulin, right, where you have a syndrome of an insulinoma. And there are a number of different types of neuroendocrine tumors that can produce ACTH. And so we can have ectopic ACTH production that leads to a syndrome of adrenal hormone excess. Things like Cushing syndrome, hyperaldosteronism, and virilization, all of which are findings here. So the question then becomes, well, how are we going to get more information, or how can we further examine that hypothesis of, is there a neuroendocrine tumor potentially underneath here? In many cases, we will see, or I should say, in many cases, it is very difficult for us to find a neuroendocrine tumor on exam. That will oftentimes, I should say, it is rare for there to be a palpable mass. It's also rare for there to be an overt imaging finding of one of these ACTH producing tumors on a traditional study like a CT abdomen and pelvis. But we can rely on the fact that these are active hormone producing tumors, if that is what we are dealing with here, to use imaging that looks for where these hormones may be coming from. So we can have certain special types of abdominal imaging, like somatostatin-based imaging, or something called, I think it's called DOPA-mediated imaging for these ACTH-producing tumors, which are basically different nuclear medicine scans that help us examine for, not necessarily is there a mass that we can definitively see, but can we look for areas in which these tumor cells are going to sort of light up bright, similarly, sort of like a PET scan, but a PET scan for particular neuroendocrine tumors. Where we're going to start, obviously, in this case, by the fact that we have a palpable mass, is probably to get cross-sectional imaging to get a better look at this abdominal mass and to get a better look at this pulmonary process that's happening here. And then we can sort of, again, continue to evaluate our hypothesis with some serum testing. So maybe we get something like a serum cortisol level, a serum aldosterone level, and a serum ACTH level to help further examine whether we are in fact dealing with something like ectopic ACTH production. And then again, focusing on evaluating the mass that we have here and the pulmonary process. Oh, I see Barbara is potentially saving me from putting my foot in my mouth. Oh, this is the number one facilitator mistake. Do not invent a physical exam finding that is not there. Barbara, thank you so much for saving my butt there. In that case, I retract everything I just said, and let's just go ahead and move forward with this case and see, are we indeed dealing with something that is in the endocrine axis, or a third party that is potentially producing ectopic ACTH levels. I'm feeling embarrassed, flush in the face, but also very grateful to you, Barbara, for saving my butt there.
Oh, don't worry, Jack. You're great as usual. So we have a chest X-ray, and maybe I can show you the chest X-ray. An image is worth more than 1,000 words, as they say, right? Okay, so can you see it?
And just to be clear, what Barbara corrected is that there is no palpable abdominal mass, which I said that there was. There is no palpable abdominal mass. We are dealing with just a left lower, diminished breath sounds over the left lung field and signs of adrenal excess on exam. Thank you again, Barbara.
So the chest X-ray showed a left-sided pleural effusion, and there was a thorax centesis made and showed a pleural LDH of 654, and the serum LDH was 268. So just to give a little bit of more information, this patient's potassium was aggressively replaced, but continued to run low. And she underwent investigations for her hypokalemia, elevated blood pressure, virilization, and pleural effusion. Okay, so I'm going to stop there to give you guys so place to think.
Awesome. So rather than the abdomen being a place that we can localize here, we at least have another place that we can start to think about being the thoracic cavity. So I'm going to give, again, a couple seconds for anybody who's watching the audience to share some thoughts about how this chest X-ray finding is potentially helping you, as well as these the pleural fluid studies that we have here as well. And while people think about typing, I think, right, what we can now say is that we have sort of localized potentially this cause of this patient's shortness of breath into the pleural space. And then we have at least definitively identified that this pleural effusion is indeed exudative in nature. So we have signs of an exudative pleural effusion based off of the high LDH level, as well as these ongoing features of there being high adrenal hormones. Again, high cortisol levels based off of the Cushingoid appearance, high aldosterone levels, which it sounds like we're continuing to grapple with due to the fact that there is profound ongoing hypokalemia, as well as high sex hormone levels based off of the chief complaint in the story. And so if we start to now try to connect these two dots together, pulmonary disease causing an exudative effusion and something causing what seems like elevated adrenal hormones, we start to potentially be able to focus our cognitive energy on something within the lung space producing ACTH that's leading to adrenal hormone stimulation. And again, like we were saying before when we were talking about the abdomen, ACTH level or hormone tumors or masses or malignant processes that produce ACTH are usually going to be neuroendocrine in nature. We frequently talk about neuroendocrine tumors of the GI tract, but small cell carcinoma of the lung is another neuroendocrine tumor of the pulmonary space. I see Vale talking about sort of a general approach to exudative pleural effusions here. Vale, do you mind unmuting and sharing a little bit more?
Yes, I was actually just trying to look up what if Meg syndrome could cause exudative effusion. Apparently it does. And also I wanted to ask if there's like a predilection for Meg syndrome to occur on the right side, because I remember that catamenial pneumothorax usually occurs in the right side because of something on the peritoneum kind of flow of fluid or something like that. And I was just reviewing the schema from the page, and it also mentioned that Meg's usually occurs on the right side. So I don't know if maybe that is the left makes it less likely, or is like 50-50, or is not that common to find it just on the right side as catamenial pneumothorax.
I would say that is a great question, but I do not know the answer to that. I think you have actually taught me about catamenial pneumothorax also oftentimes occurring on the right side. I'm curious if anybody in the group knows whether or not Meg syndrome has a predilection for the right side, because that is a great question and one that I do not necessarily know the answer to. Well, while people are thinking about that, Rafa, I think you mentioned that you wanted to share the chest X-ray overall. I'm no radiologist, but that indeed looks like it is a pleural effusion here. Just to sort of highlight the features of the pleural effusion that we're seeing, right? We have this very clear meniscus, this sort of whiteout of the lung, and sometimes it can be challenging for us to decide, is this a consolidation, right? Something within the actual lung tissue, or is this something that's in the pleural space? And in this case, we have this sort of meniscus, or this sort of sloping convexity, this sort of convex shape to the pulmonary opacity, which again looks very much like layering fluid within the pleural space. So again, based off of the chest X-ray, we have very clear evidence that this is a pleural effusion. The question becomes, is there also something underneath that pleural effusion within the lung tissue itself? Because this effusion can sometimes potentially make it more difficult to identify a coexisting pulmonary opacity, such as a mass-like lesion. So I would be curious to see here if the group or if the team taking care of this patient also got cross-sectional imaging of the chest, because again, as Vale said, we have this exudative effusion. The common causes would be things like cancer, infection, or autoimmune disease. And again, the fact that we may be dealing with ectopic ACTH production here ratchets up cancer even higher on the DDX of the cause of this exudative effusion. So our hunt is potentially on to look for potentially a pulmonary mass here to see where things are going to go going forward, but also keeping in mind that the pleural effusion could be existing for one reason, and we're dealing with a primary endocrine axis problem that's causing some of these features on exam. I see Lev raising his hand. Lev, please feel free to unmute yourself.
Cool. Hey guys, it's Lev. I was on a couple days ago. Especially for the students, because you don't get a lot of chances to do, I think, procedures in general. I wanted to remind you guys that when you see a pleural effusion that looks like this and you're going to do a thoracentesis, if you're the primary team, it's actually much more helpful to get your CT scan if that's what you're going to get after the thoracentesis is already done. Because if you get the CT scan before the thoracentesis is done, even though it's good imaging, you might actually still have a lot of compression of lungs that won't be able to let you see the lung clearly on your CT scan. So do your thoracentesis first, if you can, to allow the lung to re-expand. And then once you do your CT scan, you'll have an expanded lung and a much better window to see whether there might be a malignancy there or not. Just a very like practical thing that might be helpful.
Awesome. Thank you so much, Lev. Rafa, I'm going to turn it back to you to take us forward in the case.
Okay, so there was a CT thorax, abdomen, and pelvis done, and it showed a 6.2 over 5.9 centimeters mass in the right adrenal gland, with features suggestive of a carcinoma rather than adenoma. There were enlarged lymph nodes throughout the abdomen, and also lesions in liver and lung, consistent with metastatic lesions. And there's just one more aliquot.
Amazing. So I will be totally honest with the group here. This is not what I was expecting. I was sort of centered on the diagnosis that the primary scene of the crime was going to be in the lung space, and that whatever was happening in the lungs was leading to the problems in the adrenal gland. But what we now have here is the fact that it seems like the adrenal gland is actually the scene of the crime here with this large adrenal mass, and that the problem within the adrenal gland, which seems like it is a adrenal cancer, has spread to the lungs and caused pulmonary masses, as well as this what is likely to be a malignant pleural effusion. I'll be honest, my DDX or approach to an adrenal mass is quite limited in terms of cancer or a benign lesion. And so I'm curious if there's anybody in the group who has learned from prior VMRs ways to think about the finding of an adrenal mass, and sort of how to think through establishing a definitive diagnosis here. Well, maybe then I can turn it back over to you, Rafa, to teach us a little bit more about what the final diagnosis ends up being here. But it seems like we have a very compelling picture for a tumor that is sort of starting within the adrenal gland to potentially metastasize to others. Oh, Vale, I see Vale raising her hand again. Vale, I'll let you unmute yourself if you have something to share here.
I actually have a question, because I remember from previous VMRs thinking about masses like, but not like this, something like an adenoma or. But they were mentioning sometimes that a venous study will be useful, because sometimes we see a mass on imaging, but doesn't necessarily mean that the mass is the one secreting the hormone. So I don't know if I wanted to ask if in this case, it would be necessary to do some venous studies on renal veins, or if with this imaging we can just proceed to do a surgery and just remove the mass.
This is an absolutely phenomenal point, Vale. So I think just to highlight for everybody listening, the finding of an adrenal lesion is not an uncommon finding. We oftentimes will see adrenal lesions. The question then becomes: is this a true functioning adrenal lesion, or is this what we call an adrenal incidentaloma? And oftentimes, what we have to then do to confirm is this an adrenal incidentaloma or a functioning adrenal mass is to ask the question: is this adrenal tumor causing abnormal levels of adrenal hormones? And we will oftentimes do what's called adrenal vein sampling to take blood from the ipsilateral vein that the ipsilateral drain on the same side of the tumor, to look for abnormal levels of hormones in that blood. And if those tissue levels, or if the blood levels of the hormones are high in that vein, then we can say that that tumor, or that lesion in the adrenal gland, is likely hyperfunctioning and causing these types of symptoms here. That I would say that approach applies to sort of to adrenal masses in general. Where it becomes, I think, a different calculus is when you have a very, very large lesion like this, or when you have signs that or other imaging findings that increase the probability of this being malignant disease with metastatic lesions. And so I would certainly be curious to learn whether or not the team underwent adrenal vein sampling, but the constellation of a large mass, proximal lymphadenopathy, and distant potentially metastatic lesions makes me think that it's quite likely that this, I would say that those things together increase the probability of this one being a malignancy, and the fact that it's a malignancy makes the fact that it is hyperfunctioning also have a higher probability. Whether or not somebody would go through the exercise of doing the adrenal vein sampling or go straight to some sort of other procedure is something that is very much beyond my scope of knowledge here. And I think further the decision on whether to undergo surgery is probably further impacted by the presence of metastatic lesions here. We see this excellent infographic being shared from Tiago's Twitter here that sort of, again, is highlighting the different ways that we can think about these adrenal lesions that we find. So some of the features that we might see is, again, the irregularity of the lesion. And as Kirtan is mentioning in the chat, the Hounsfield units of the lesion can also be helpful, which is something that radiology can examine for us. Kirtan, if I can turn it back over to you, do you mind sharing a little bit more here about what you've learned about the role of Hounsfield units here?
Yes, sure. Thanks for passing it over. So actually, as I mentioned in the chat long back, that this is what I learned from Dr. Thiago Mendes. Actually, I had seen this infographic few days ago. So Hounsfield units is very important because it tells us that what's the lipid content of the tumor and what's the fibrous content of the tumor. And sometimes it happens that the relative levels of those two things determine the malignant potential of some tumor. And that's why Hounsfield units above 20 units, and sometimes some reports suggest that Hounsfield units above 50 units, it's more sensitive and specific. So if we have that, then we are assured of the fact that this is not just incidentaloma, and actually it is the tumor which is secreting the hormone. So it is the active lesion. And this contrast washout is also very important. So usually what happens when the tumor is metabolically active, then there will be delay in the contrast medium washout. And usually the time frame is like 5 to 10 minutes. So like if you give the contrast and after 10 minutes, if there is less than 50% washout, then we are more likely dealing with adenocortical carcinoma rather than the benign lesions. So in our case, I agree with you. Either it's adenocortical carcinoma or maybe a metastatic lesion with the primary foci being in the cancer or maybe even ovaries. We are not sure of that yet.
Excellent. Thank you so much, Kirtan. So to sort of anchor that teaching, as we were just discussing back to Bali's question, the imaging features of this particular lesion decrease the probability of this being an incidentaloma and have features suggestive of a primary adrenal malignancy or a metastatic lesion that has made its way to the adrenal glands, both of which are potentially a contention here. So I think a question that we have to ask is, have we gone from lung to liver and adrenal glands? Have we gone from adrenal glands to the liver and to the lung? And how we can sort of link those together. I would say I'm curious to learn from Rafa here at the end here about how the sort of presence of, just to be clear, was there also liver lesions here or no?
Yeah, Jack, you're not making it up this time. There was liver metastasis.
So the fact that there are liver mets makes me wonder if the primary tumor site has initiated in the abdominal cavity, made its drain sort of through the portal venous circulation to the liver, and then also has made its way to the lungs. But I think both of those potential hypotheses are here in terms of where the primary tumor originated, whether it's something that has started in the adrenal glands or gone to the adrenal glands. I think we'll hopefully have an answer to within the final aliquot. But the bigger picture take home here is that the imaging features, exactly as Kirtan and Bali walked us through, the imaging features here make us much less concerned about an incidentaloma and much more concerned about a malignant adrenal mass. And again, things like the Hounsfield units, the size, and the irregularity are features that can be helpful in making that determination without the need to get adrenal vein sampling, which sometimes is also helpful to see if this is a metabolically active hormone here. So Rafa, a metabolically active tumor here. So Rafa, I'll turn it back to you to sort of take us home in this case.
Just to make sure, is Levi raising his hand again?
Oh, great question. Lev, did you have something else to add, or this is probably a facilitator error on my part by not putting your hand down.
Forgot to do it. No, we're all good.
Thanks, Lev. And thank you, Rafa.
So, okay, so this is the last aliquot. So the renin aldosterone ratio was normal. Urinary metanephrines, negative. The 24 urinary cortisol was elevated. It was 5.5 times above the upper limit. And the GHEAS was 18.9, being elevated. And that's the last aliquot.
For the sake of time, Rafa, go ahead and just take us home.
Okay, so this was compatible with adrenal cortical carcinoma. The patient was diagnosed with metastatic adrenal cortical carcinoma based on liver biopsy. Her hypokalemia and hyperglycemia were believed to be consequences of glucocorticoid excess and the virilization, the result of excessive production of adrenal androgens. And after discussion with her oncologist, she decided on a palliative approach with a focus on comfort. This is because many of these patients, they present in a very advanced stage of the disease, unfortunately.
It's a devastating case, and incredibly sad to see in somebody who is very, very young still. I think highlights, again, I think the point that you mentioned, Rafa, there about how oftentimes late in the disease course, these can come to clinical attention is humbling, sobering, and really quite sad. And I just want to thank you for bringing this case to all of us to learn from today. I think one reflection that I have, in addition on the just how sad of a sort of how sad of an outcome this is at this in this final aliquot of clinical findings, right? The finding of there being normal aldosterone levels, even though there are sort of features of, again, the hypokalemia, which we may think of as being something mediated by elevated levels of serum aldosterone, I think highlights that there is a lot of overlap in terms of the different ways in which things like cortisol and aldosterone influence the end organ manifestations of these hormones. And so, right, sort of thinking about how hypercortisolism can give us a signature that looks similar to hyperaldosteronism highlights the fact that there is sort of a substantial amount of overlap between these primary adrenal hormone excess syndromes that we may ultimately end up seeing. I'm curious if there's any other reflections from those of you in the chat in terms of learning points from this case, or anything else that you're particularly taking home here. Well, with that in mind, I will turn it back over to Daniela to take us through some of the teaching points today. Also, for those of you who are new to VMR or who are new to this format, I will be upfront, and this is a format that I have not tried too often before, so it sort of is a new trial run. If you have feedback in terms of things that work, things that didn't work, feel free to send me a direct message here on Zoom. I would love to hear from you how this session felt overall, and whether or not it's something that you would like to continue to do as we continue to work on iterating the VMR space to make it as educational and as fun as possible. But that is enough from me here. I will turn it over to you, Daniela, to take us through some of the teaching points for today.
Hi, everyone. My name is Daniela, and first of all, I'd like to thank Rafa for bringing this very humbling case. And I really like hearing a little bit of everyone's discussion. I will now share a little of my teaching points for the case. First, we have the discussion on development of traits and symptoms that are classic to males on a female patient. In this case, it is important to consider the tempo, see if it is acute or chronic, and hormones, if there is any indication of alteration, recent or chronic as well. The easiest way to assess this in women would be to see how the menses are doing, if the woman is already in perimenopause, in menopause, and the characteristics of the menstrual cycle during her life. Also, in this development of traits and symptoms, we have to consider the possibility of being an endocrinology cause or a malignancy that is causing these symptoms. And with the beginning of the case, we had facial hair and acne, which leads us to think about an elevated androgenic hormone. And continuing with the case, we see that this patient has hypertension and hypokalemia. So we have to think of what can mediate both of them, both blood pressure and potassium levels, and what are the other symptoms or signs that can lead us to think about some of these causes. Some hypotheses that were brought up were hyperaldosteronism and hypercorticoidism. And then we went on to think what can cause all of these manifestations to happen. Shortness of breath can be caused by cardiac disease and hypertension that was developed later, or maybe it could be a pulmonary process. And amazingly mentioned the possibility of coexisting causes such as obesity. And with exams and labs, we had some other options such as ovarian cancer, which could have some effect on blood pressure and pleural effusion. Meg syndrome, which would be very similar with ovarian cancer or mass, pleural effusion, and ascites. And we also have to keep in mind the endocrine causes, such as neuroendocrine tumors, which can lead to hormone disbalance and excess. And with pleural effusion, we started thinking about exudative due to ACTH production, and tumors in the pulmonary space could do that. And we also learned that thoracosynthesis before CT scan would be very important for better visualization. And adrenal mass, we have to consider if we have to investigate more, or is surgery already a possibility. And if it is an incidentalloma, that can be helped by doing sampling, evaluating the possibility of distant metastatic lesions, and also the characteristics on imaging. It is also important to find the primary tumor if possible and its location. And we also learned from Rafa that adrenocortical carcinoma usually has a late diagnosis. And I think with this case, we'll learn to keep it in mind as soon as possible. Yeah, I think that's it. Thank you.
Awesome. Thank you so much, Daniel. Those are absolutely phenomenal teaching points. I want to thank everybody again for coming out today. This was so fun to have this sort of crowdsourced teaching that Daniela summarized brilliantly at the end here. And then also there's a couple people who deserve a shout out who I didn't see present in the actual participant list, but who were huge drivers of the teaching here on the adrenal masses. We mentioned Dr. Tiago Mendez, but also Dr. Gabby Pucci as well, who looked like was a part of creating the adrenal incidentalloma and adrenal mass schema. So thank you, Tiago and Gabby, for teaching us, even when you are, or I should say, teaching us from afar. And it is, again, so much fun to have you all here. This was a blast and a really excellent case to think through. Again, please feel free to share feedback with us about this format overall. Would love to hear how to make it better beyond just knowing more about adrenal masses, which is on my to-do list for reading today. And I want to thank everybody again for coming. Hope you have a great rest of the day, and we'll see you next time.